Dear friends, you are about to start your vitrectomy and you need to make choices to best control your action through the procedure. In particular, you must choose your means of lighting and your optical system when you are inside the eye. Let's first take a look at your illumination system. I will be much less categorical in promoting the advantages of the slit lamp in vitrectomy for detachment than for a vitrectomy for macular surgery. In macular surgery, you work at eye magnification. The surgical field is almost completely eliminated by the slit, and you don't need to control everything in the periphery. Here, it is different. And I can understand that, at least at the beginning of the career, an operator, already stressed by the control of his handpiece, wants to control what happens all around, including in the periphery, and doesn't want to see in the restricted operated field a retina attracted by the vitreous suddenly appearing like a devil coming out of his box. This is understandable, especially for the realization of the central vitrectomy, where the coherence of the central vitreous pancake can attract the retina from a distance. The problem is that if you want to use vitreous optic lighting, to have a wide illumination, you have to do either a third sclerotomy to introduce the fiber or two small sclerotomies to fix a chandelier. To avoid this, some early career operators, convinced by the slit lamp because of its advantages in peripheral vitrectomy, use a wide field lens for the central vitrectomy, with the hole themselves on the cornea, since the slit lamp frees up one end. Once the central vitrectomy is done and there is no more continuity with the vitreous pancake, the risk of attracting the retina from a distance no longer exists, and they can continue the peripheral work without a wide field lens. This is what I did in the past when I put the gimbalk lens in. Admittedly, the illuminated field is not as wide as with the fiber, but enough to control what happens in the eye. But very quickly, with experience, I realized that I no longer needed this global vision, and so I did all my vitrectomy thanks to a plano-concave lens, while keeping the only lighting of the slit lamp as my unique illuminating systems, since its advantages are numerous, linked to three specificities. First of all, the fact that it is a slit, allowing an optical cut of the transparent media, allows not only the identification of the vitreous and the posterior haloid, but also the posterior capsule, and this is a considerable help when we want to remove the anterior haloid without touching the lens. Secondly, the fact that the illumination is fixed to the microscope offers the advantage, as we just seen, of not having to perform an additional sclerotomy and therefore reducing the risk of vitreous incarceration. But in addition, compared to the intraocular fiber held by the surgeon, the slit lamp has the enormous advantage of freeing one hand that they will use to center the contact lens, to stabilize the membrane forceps, and especially to perform the scleral depression by themselves during peripheral vitrectomy. And here we tackle an essential chapter in the realization of a complete vitrectomy, the need to perform a scleral depression, which will have two beneficial effects. on one hand, at the base of the vitreous, the indentation will propel this base in a centripetal way and make it accessible to the handpiece in a phakic patient, even when it is necessary to work in front of the entrance of the handpiece. On the other hand, and whether it is this time on the posterior part of the vitreous base or much more posterior, even retroequatorial zone, the scleral depression, by carrying the retina beyond its position of rest, is going to placate it on the indentation, to exert an effect of suction and allow it to accept a traction which, on a non-stabilized retina, would have caused a tear. This is why, when we want to perform the posterior haloid peeling, it is essential to exert a scleral depression as far as these retroequatorial regions, and therefore to perform a conjunctival incision. The realization of this scleral depression must be very precise, sometimes lighter, sometimes more important, sometimes more posterior. It must be part of a two-handed surgery concept, and therefore cannot be performed by the assistant with the same precision. It is like asking the assistant during a phaco to hold the lens for cracking. The assistant cannot hold the endocular fiber either. As the endocular fiber monopolizes the surgeon's left hand, the completeness of the peripheral vitrectomy will be affected. Similarly, during PVR dissection, the surgeon under a slit lamp may very well perform a third sclerotomy to insert scissors or forceps and easily perform a bimanual surgery. This is why chandeliers were invented, because they also frees up the surgeon's second hand. But in addition to the two small sclerotomies that could be dispensed with, they also present a small problem: the impossibility of indenting the vitreous base behind them without the risk of propelling them into the lens. So some of you will tell me, yes, but you can also remove the lens at the same time. It is done in many places. Okay, but in one hand it is difficult to calculate the power of the ideal IOL on an eye with detachment, and then why prolong the procedure and increase the trauma when you can do otherwise? The third specificity of the slit lamp is its shift to 5 to 7 degrees from the optical axis. This has two effects. Firstly, and this is shared with the fact that the lighting is limited to the slit, this will allow details to reappear that would not appear under a wide fiber optic lighting because they are too flooded with light. With the slit, the detail will emit a reflected image that will not be drowned out and crushed by the abundance of light. The second effect is seen especially during peripheral vitrectomy under scleral depression. Since the axis of illumination is close to the visual axis, the slightest small vitreous relief adhering to the retina will appear in a row, silhouetted like a tree in the top of a hill. This gives a very strong feeling of having seen everything, even the smallest details, which I can only explain by telling you this story. A mother spills her sewing bag in her baby's room. There was a spool of thread, a thimble, and needles. If she climbs on a stepper ladder and lights the floor of the room with a halogen, she will only see the spool of wire. This is what you see with a wide field lens because the magnification is not enough. So she will take a flashing and illuminate the floor around the bed, around the chair, and discover the small thimble. This is what we will have with a plano-concave lens and intraocular fiber at high magnification of the microscope. But she won't leave the room without checking that there is no needle. So what is she going to do? She will put her eye on the ground and light with the torch tangentially to finally detect the needle heads coming off the ground. And she will only leave the room after having done that. It is very subtle feeling that one feels with the slit lamp. The certainty of having identified all these small details thanks to this tangential lighting. I've never experienced this feeling with any other lighting system. That's why I encourage you to choose this solution, even though I know that at first you will be bothered by reflection, especially with the plano-concave lens, but you will soon learn to eliminate them. On a practical level, you can see how to install the slit lamp in Chapter 5 of the playlist of the macula. Not for those who use a 3D system, that slit lamp lighting is not only compatible, but gives even more spectacular result. And since we are talking about 3D system, I would like to say that I am not opposite to them. In fact, I've done 3D tests with Zeiss more than 20 years ago with an incredible 3D vision, even too strong. I would just like to make a comment. If what you like in this system is to be able to show on a big screen a beautiful image that visitors or staff will follow with interest, know that for much less you can buy an HD camera with an HD SDI output that you will connect to a big screen thanks to a graphic card, and that will give you a picture quality infinitely better because less compressed than the one provided in 2020 by the 3D offers. Then of course this image will not be in relief, but it will evolve over time according to technological advances. One advantage of 3D system for young non-presbyopic operator is that the focus will always be perfect because they are looking at the screen and therefore their focus is not influenced by accommodation. And this leads us to talk about visualization means, that is to say, optical system to visualize the fundus. The two grid systems which oppose or complement each other are the plano-concave lens and the wide field system. Both have their advantages and disadvantages. The plano-concave lens gives the best image quality and should be used in priority when it comes to peel a membrane. The wide field system gives a better overall control around the work area, also allowing a visual control during an exchange through a gas bubble, which the plano-concave lens does not allow except in the case of the aphakic patient. It is therefore necessary to have both systems available. It is difficult to advise young surgeons on the use of one or the other of these two systems because it depends on many things specific to each one. First of all, the system they learn about in the hospital. They have made effort to master the system and will tend to keep their habits. It depends on the lighting system they have chosen. If they have chosen an intraocular fiber in order to reassure them in the peripheral control, they will be more likely to opt for a wide field system. It also depends on how demanding they are in the completeness of the vitrectomy. For example, a perfectionist in the quality of the vitrectomy will have to choose to do the peripheral scleral depression himself and will probably have opted for a slit lamp lighting. He will therefore be more inclined to choose a plano-concave lens that will give him the best visual of the details. Finally, it depends on a lot of choices, such as the position of the trocar and how to remove the vitreous around the trocar. For example, since I place my two trocars at 11 at noon and didn't want to make a scleral depression behind them, I used a 3-mirror lens for the peripheral vitrectomy between 10:30 and 12:30. But doing a vitrectomy in a mirror is not easy. You have to be able to disconnect your brain from its gestural control. The bag tongues say that it was easier for me because my brain is not very complex. So I will simply tell you why I chose to perform all my vitrectomy except for rare leakage gas exchange with the FCI plano-concave lens. It is a single-use lens surrounded by a small silicone skirt, small enough to allow the mobilization on the lens on the eye without the skirt hitting the trocar. The skirt has a small ring that allows to hold it with a forceps and turn it over to deposit a viscous product in the concavity of the lens. The lens is thus excessively easy to handle. Its relative mobility in the cornea is one of its main advantages. In fact, the prismatic effect caused by its inclination on the eye gives it the capacity to have a continuous visualization of the entire retina from the macula to the pars plana. When you do your peripheral vitrectomy, the scleral depression that you perform causes the glove to tilt towards the area you are looking at. If you drop the lens towards your depression, you will have posterior pole vision. If your assistant holds the lens higher on the cornea, almost horizontal, you will have peripheral vision all the way to the ciliary body. So you can see the entire retina without the need of a prismatic lens. You will maintain the image quality associated with this type of lens. This is to see an image that is infinitely larger and sharper than with a wide field lens. These were my choices. I am well aware that not all of my choices are in the line with the current trend. It is certainly more up to date to do a vitrectomy without incision of the conjunctiva because it allows to have a white eye the next day. But you have to put things in context. In the indication for vitrectomy that I have described, the clinical pictures is serious enough to require a complete vitrectomy with notably a peeling of the adherent posterior hyaloid and a very precise and complete action at the vitreous base level. If conjunctival incision is not performed, no retroequatorial scleral depression will be possible, which is essential for the peeling. In this case, a very high-speed shaving will have to be used, which will allow the surgeon to work along the retina without moving it, since he will not remove the adherent hyaloid. Similarly, at the periphery, the scleral depression performed by the assistant will leave more anterior vitreous than if the surgeon had done it himself, especially since he will have continued to cut at a very high speed, worked by the illusion of having removed everything from an immobile retina thanks to the performance of this new machine. The surgeon will probably not realize that, as proven by the EVRSRD study, he has, with this technique, 3 times more failures. But does not his clientele continue to increase? And anyway, a retinal detachment is something serious, isn't it? My approach was completely different. My preoperative and intraoperative clinical finding research aimed to identify everything that needed to be treated, so as to treat everything but only that, because any excessive trauma is paid in terms of functional results. This explains why I have always given preference to image quality over comfort, and this is why I have chosen the slit lamp and the plano-concave lens. In the same spirit, my search for efficiency and quality has led me to improve and develop the ergonomic and fluid characteristic of vitrectomy machines in order to push back the limit of this incredible infernal gamble of wanting to remove as much vitreous as possible, but without causing traction, which is difficult to reconcile. This is what we will see in the next chapter.